So thanks for coming. This is another equipment issue that I wanted to share with you. So another thing about rich emotional experiences, I think we all are exposed to these, very memorable, terrifying perhaps, but the goal here is to learn from them. And you know, as an attending, I never taught a fellow to pull hard. That's really counterintuitive to what we want to do. But sometimes, perhaps just like you saw that Burr case, pulling hard is what it takes. Failure preparation is preparation for failure. That's the theme. This is a 70-year-old man with an ischemic cardiomyopathy. His EF is 30%. He has previous stents in his RC and LAD, and he had this moderate obtuse marginal lesion on his last cath. He clearly had worsening exertional throat tightness, which is his Angelini equivalent, and so we brought him to the cath lab. We get radial access, and we perform diagnostic angiography, and you can see that his RCA stent is widely patent, as is his LAD stent, and I think you'll see here that there is a focal lesion in that obtuse marginal that I'd probably say is in the moderate range, not obviously super tight, but he had escalation of symptoms. And so I think most of us nowadays are comfortable doing in the lab physiologic assessments. And so we went to a guide catheter and we performed FFR, and this is before we had IFR with maximal hyperemia, and his FFR was positive at 0.74. We did this on intravenous heparin. And so we felt like we've demonstrated a physiologic lesion there with symptoms, and so we were going to fix that lesion to relieve him of his symptoms. He got prasugrel in the cath lab and bivalirudin. He was not still on clopidogrel. And then, we went for a 2.5 by 15 balloon for predilation. And I say, come on now, because I don't know about you guys, but this, balloon looks, relatively well inflated. I didn't really see any of that. That's a fluoro save, and we usually do IVUS-guided balloon angioplasty and stenting. So after this balloon angioplasty, we performed IVUS with the pullback system, and you can see here that there's some calcification there, and we could argue about the degree of that and whether or not rotational atherectomy at this point would be indicated. But at the time, I'll be honest with you, I really wasn't thinking that I needed to rota this, to be honest. It didn't look that calcified, and the balloon looked like it dilated pretty well. So I took a 2.5 by 22 resolute DES, and everything's fine, and the patient's doing well. And I put that stent in there, and it looks actually in this view, this is just before we stented it, and this is just after we stented it. I mean, if you look at that lead, it looks okay, and here I am with the stent, and now with the stent in there, I'm like, wait a minute, there's a little bit of a waste on that thing. You can see that there's a waste there. So, what do we do with the waste? We just post-dilate it. So I took a 2.5 by 6 NC to 10, 18, and 26, and the waste was still there, and I tried to develop an angiosculp. I think we've all experienced this. Sometimes it just won't deliver, nor would a cutting balloon probably in that case. So, we take an Impera. There's different NC balloons, and some I feel like have a better sort of inflation characteristic. So I went pretty high, 18, 20, and 30 atmospheres. When I was a fellow, I really wouldn't go that high. I think as you become comfortable, you realize that it's pretty infrequent for these balloons to burst. And this is where the rich emotional experience begins. So you do this. And this is just showing you this is what that waste looked like. And so, clearly there's a waste there, and I think none of us would like to leave a waste like that in the coronary. I think we probably all agree that it increases the risk of instant restenosis there, if not thrombosis. So at 30 atmospheres with the, I knew we had ruptured because the insufflator lost its pressure. And then here you are, I'm trying to take this balloon out of there, and of course the guy just starts deep seating. And if you replace an S with a W there, or a W with an S, that's kind of the feeling. And you're like, what do we do now? And no panic, we're okay here. This is a balloon that's just not coming out. And let's call a spade a spade. You guys can attack me and say, hey, come on, Tsai, better lesion preparation. Should have just done some better. Well, I didn't think it needed better lesion preparation. Of course, this is just the algorithm. You can do high pressure NC balloons, you can butter wire score with the NC balloon next to it. Of course, there's different atherectomy, rotational, orbital, laser. And again, you can use these cutting balloons. The Wolverine balloon, go blue, is the new Boston Scientific cutting balloon, or this angioscore, chalk, whatever you want to use here. But we didn't, because it didn't look like you needed it. And then, of course, there's these case reports of these stuck coronary angioplasty balloons as a surgical emergency. So this particular case here, a balloon, this is a stent balloon, got stuck within the stent. They pulled, the catheter broke. Patient went to the OR. They did arteriotomy and pulled out the stuff here. And this isn't really what we want for our patient to go strictly to the OR. And so we got to figure something else out. And so now, of course, you know, with that balloon in there, he's having some ST elevations, some chest discomfort. He's wondering what's going on. And so there's some options here. We can pull harder. And I think Dean pulled pretty hard, probably, Dean, right? When you, but that's a very uncomfortable feeling, pulling hard like that. The guideliner assist, I just want to emphasize that this is a great device to sort of bring the pressure points to a different area. Last thing you want to do is pull on that balloon and have that guide catheter dive in. Or even pulling on the guide catheter and the balloon together, you get these forces along that wire where you have this, the left main, the LAD. You can try and get a wire next to it and use a microcatheter. You can try and get a catheter over the balloon catheter to try and change your forces as well. You can snare the balloon also, but again, there's a lot of force going on there. So these are all the things going through our minds. This is an example of the guideline assist. Here's a 6 French guideliner, 6 French system, and you can see it's, you just bring it right up to the balloon, and I was pulling pretty hard, very uncomfortably hard, and so I stopped doing that. You can parallel something, but the reality is, if you think about what's going on, that balloon is stuck in the stent. Very difficult to send a wire next to that thing, which is, in Dean's case, it's great that he could send a wire next to it. There was no wire going next to this thing. Fielder XT, Pilot 200, stiff wire. I even took a Corsair, which you can spin sometimes, or a Turnpike, and those nicely sometimes track, but it laughed at me. And then optimizing the physics here, you can really deep seat, but it just wasn't coming out. And the patient was having a lot of discomfort there. And so I would just emphasize that in your cath labs, you seek counsel from all your gray-haired cardiologists. I'm becoming one, but not anything against you, Dr. Rubenstein. But you ask your cardiology colleagues and interventional radiologists. They're really good at this kind of stuff too. I asked them for their counsel, and they really didn't have any other advice for me. They're like, good luck with that. The CT surgeons, we got them ready because I think the last step is to take the patient to the operating room. We kept his friends and family informed, because the last thing you want is to go out there and just tell them something bad happened. You want to keep them updated that something bad is starting to happen. You'd be amazed. That's a very useful social skill there, is to let them know that. And then having a great team. And so this is our solution. So praying for the best and preparing for the worst. So, in case we perforated or we dissected, we did this ping pong guide thing. We got access in the left femoral and put a guide up there ready to intubate the left main in case we pulled and got a perforation or dissected the LAD. And then I did this push, pull, and pray. And you may say, what are you talking about? I just pulled really, really hard. And I was comfortable pulling really, really hard here in this advancing the guideliner. So what I did here is I advanced the guideliner into that area. And so what happens here is all your forces of pulling now, you can see this guide is completely stable. It doesn't get pulled in. You don't get pulling on the wire. You get the concentration of forces on the guideliner tip and that balloon catheter. So if something's going to happen there, it's going to happen at this site here as opposed to in this area, theoretically. And amazingly, I pulled as hard as I could, as I pushed the guideliner as hard as I could, and everything came out. And so there was about 35 people in the room, the surgeons, the OR was ready. And I took a picture, and thank God, the balloon came out, the guideliner came out, the wire came out, but the patient was hemodynamically stable. And so 10 minutes later, we basically just waited to see if something would emerge as a complication from this, and the guy did fine. And you can see here that there is still a focal waste in that area. And to this day, people ask me, hey, did you rewire that in IVUS? And I said, are you crazy? Rewiring IVUS? That, like, the guy's doing fine now. So And thankfully, this guy, 16 months later, he just came December of 2017 with some atypical chest pain. And we went in there, and actually the lesion looks the same and an FFR negative, so we left that alone. And so I think, in this particular scenario, we got out of a tough situation. My take-home points is obviously lesion prep. And you can't know every lesion that needs preparation, and maybe I should have cinied instead of fluorosaved that balloon inflation to see the waist, because I think if I would have seen that, perhaps I would have done some rotational atherectomy. Exhaust your resources, use all your friends, IR, colleagues, get the CT surgery team ready. Praying is okay, but you got to prepare for the worst. So I do think getting a ping pong guide up there ready to go if something disaster happened, you got to do that. And sometimes leverage is leverage. And so I do think this guideliner, just like in Dean's case, if you cut the rotaburr and you could take a guideliner up over it, you can exert a lot of force at the site while you're pulling. And like Ajay was saying, you could actually use that rota wire with that fixed weld and guideliner together and probably be pretty successful at getting some of these stuck things out. If you said to me, what the hell happened? What happens is essentially when you have a waist in that balloon and you have an NC balloon with these thick folds, either because you don't wait enough for those folds to really come and wrap back on, but once you start pulling that thing and if it gets caught behind or the waist of the stent, you just have all this NC balloon stuck behind it, behind the waist. The harder you pull, like a Chinese, yo-yo trap, whatever that thing's called, I should know. If you pull harder, it just gets harder to come out. And this is a scenario, this is a picture this isn't our picture, but it gives you an idea of what an NC balloon looks like as you try and pull it out. It gets wrapped and it gets big. So these are, that's I think what happened here. And any questions or discussion? Thank you. So it didn't enter the guideliner. They came out together. And I didn't take a picture of this, but you could see the balloon basically had folded on itself. But I do think that the combination of bringing the pressure point to the balloon without guide stuff allowed you to put a lot more force on that. And to me, that was you could have just taken that guy to the OR, but I just needed to give it a bigger pull. And as long as you're putting the forces in the right places, I'd say if you're ever going to pull like that, it should be with a guideliner assist.
You cut the back of the balloon, right?
Yeah, so you had to cut this was a over-the-wire balloon, NC balloon, and so, I'm sorry, this is a monorail, so obviously you got to cut it. But if you cut it, no problem, you just put the monorail guideliner over it, and you have the support of the guideliner and the balloon shaft.
So Tom, in our case, we use a trap balloon also to keep the force forward. So we put a 3030 right down alongside it, inflated it, so you had the guideliner, so everything was kind of trapped in there as hard, and that's kind of give us an additional tug technique.
Andrew's technique is if, you're not going to be able to push and pull with that technique, but it keeps everything stable and you can pull everything as a unit. Yeah. The advantage of the guideliner allowing it to be free is you can push and pull at the same time. So I think the amount of forces you can generate is much higher.
Just another comment too. One of my senior partners retired about 5 years ago. When they were just ballooning back in the day. When something doesn't necessarily give and there's still a waist, I would do the same thing. I'd crank it up and just get a bigger balloon, crank it up. And he's like, Dean, whoa. It's like, don't go bigger on the balloon, don't crank the ATMs, but just go for a super long inflation for several minutes. And believe it or not, I've had a couple cases which I didn't notice it either, and the stent actually after cracked and expanded after not crazy high inflation, not a crazy size diameter balloon, but keeping it up for 2-3 minutes, and it just would finally give. So just something to think about.
Yeah,
it may not work all the time, but just something to consider.
I mean, those atmospheric pressures you take, we do them routinely, but I wouldn't take a bigger balloon than the artery size. So the fact that you were 2.5 was a good thing. The one thing and again, this is not to be nitpicky, when you get that out, you don't want to do anything further. But there are times when the balloon ruptures that the entire fragment of the balloon, and sometimes not with the markers, is not out of the body. So you have to look at it, and there are ways we've had cases where there's fragments of the balloon still left inside the stent. If you're really not sure, you can image it and OCT it. The final thing is if that have fragments left, and also with the guideliner down, the stent can have longitudinal compression. And we've had cases where exactly the same thing for exactly the same reason you stop, and then the stent thromboses because of that. So I think you just have to be, that's why your FFR was a good thing to do, because you prove there's no flow abnormality at that site.
The other option when you have this issue of underexpanded stents is to laser through it. And I've even on a couple of occasions have had to inject contrast a bit during the laser. And we've learned that from the CTO experience. And that sometimes modifies the lesion enough to then expand it with balloon.
All right, great, thank you.
That was an awesome case, thanks.